Hello. Welcome to Kindly Neurodivergent with Kay. This show is to spend quality time with each other, kindly discussing the similarities and wide range of differences we experience. The experiences we discuss on this show are for educational purposes only. Please do not substitute for professional medical advice, diagnosis, or treatment. Before we begin, I respectfully request that if you witness any pauses during this show, please continue watching. I'm composing a spontaneous comment or question, someone processing their thoughts, in addition to repeating something that was unintelligible or misunderstood. It is natural discourse, and we can choose not to say anything while this is occurring. In lieu of National Cerebral Palsy Awareness Month, I have Dr. Selber with me. He is here to discuss the functional impact of disorders in adults who have cerebral palsy. Welcome, Dr. Selber.
Thank you, Kyla. Kyla, it's a pleasure to be here, indeed.
Please introduce yourself.
So my name is Paulo Selber. I'm an orthopedic surgeon specialized in neuromuscular disorders. I've been around for a little while. I started my career in Brazil. Then I spent most of my career in Australia. And then in 2019, I was recruited to come to this little town of New York. I started here at Columbia University and then eventually moved to the hospital for special surgery. And that's where I've been practicing for nearly 4 years now.
What is an orthopedic disorder?
Well, an orthopedic disorder is something that affects our muscle and bones in a way that precludes, natural movements or precludes us or makes it harder for us to move around and do the activities that require movement in our bodies.
Please discuss what functional ability is.
Functional ability, in my way of seeing it, is our ability, our capacity to perform tasks that we need to or wished to perform during the day. To eat, to walk, to speak, to go to the toilet, and so on. So this is what I call functional ability.
I used to need my parents' help to do homework every night, but as the material got more involved, it's easier for me to do it independently rather than explaining it to someone except for math.
That makes perfect sense.
I transfer myself from my bed to wheelchair or from my wheelchair to the couch.
That's really, really important and really incredible because it gives you independence. And in orthopedics, we try to do some tricks to help people to transfer better if they have, deformities or stiffness in their lower limbs. And the orthopedic surgeons that treat the upper limbs, they try to do some surgical tricks to the upper limbs as well.
How can orthopedic disorders in adults with cerebral palsy significantly impact functional abilities?
Yes, they can. Cerebral palsy, as you know, and we all know, produces what we call movement disorders. Difficulty with moving the arms, controlling the arms, moving the trunk, controlling the trunk, and finally, moving and controlling the lower limbs. So some people have several difficulties with controlling those parts of the body. And, some people are more able to do movements and to control their movements, and some people are less able, and they rely on alternative methods to accomplish the activities or the functions that they're in need.
Why do people with CP age faster and have increased pain?
Look, I've been discussing this very same matter with a lot of my adult patients. Even though I was trained as a pediatric orthopedic surgeon since the very beginning of my career, my first boss, Dr. Ivan Ferretto in Brazil, told me that I needed to see the adults because CP doesn't go away when they turn 18. So he was very ahead of his time. This is 31, 32 years ago. And I don't really think that people with CP age faster. I don't think it's about the aging process. I think what happens is, and this is just my humble opinion, okay? I think what happens is that because in cerebral palsy we have the movement disorders like spasticity, dystonia, where the muscles are constantly being activated. Can you imagine? It must feel like running a marathon every day. That's why a lot of people with cerebral palsy are very fit because they use a lot of energy all the time. So, and I think what
24/7.
happens is that the joints and the muscles, they tend to wear out or wear off a little bit quicker than in typically aging people. So to me, it's not that people with cerebral palsy age faster. I think it's just that they work much harder than any typically aging person, and they that puts a toll on the joints and muscles, ligaments, etc. And that's why they hurt, I believe.
Why do you not consider it aging faster?
For the very reason that I explained. I don't think people with CP age faster. I think they age just like anybody else. They can be as fit and as healthy as anybody else. It's just overuse of the muscles and the joints because of the many uncontrolled movements that sometimes they have that in a way makes the joints to wear out sometimes quicker or sooner than in typically aging people. So I don't think it's an aging process. I think it's uh, I think it's just working too hard every day.
How do you address whether a surgery will be successful as an adult?
Yeah, that's a great question, Kyla. Look, in adults, even though I've done it for, as I said, for a long, long time, more than 3 decades, we don't have a lot of publications yet. We don't have a lot of evidence to everything that we do. We copy some of the ideas that we apply in children, where there is a lot of evidence, and we transfer them to adults. But not all the ideas that apply and work in children apply and work in adults. So one has to be very careful not to apply or to think that the same, as I call it, surgical dose that's applied to children works in adults. So in adults, I am 10 times more conservative, perhaps, than when I operate in children. In children, as I said, there's a lot of data for everything or most of the surgical procedures that we do. So in people who are able to walk, even in the adults, we always use three-dimensional motion analysis or three-dimensional gait analysis to measure and to try and understand how they walk so that we can design and think about surgical interventions and very often non-surgical interventions to try and improve the way they walk. The people that are not able to walk, they are wheelchair users. Then we have to tailor the or to give them the right dose of surgery, sometimes to try and make a hip a bit more mobile, a hip that's hurting and arthritic more comfortable. So every patient is different. And that's why I love my profession, because it's not boring. We have to think
Mhm.
hard and very carefully. Because remember, the first aim of doctors is to do no harm. So in adults and in children, you have to think hard and to try and pick the procedure based on what's been written and based on your expertise and your experience, but also based on what other patients that you've applied those surgeries have told you. You know, if patients start telling me that the surgery that I didn't work, I have to take that very seriously and say, oh, what's going on here? What's happening? How can I change this? And so on. So it's an ongoing challenge. It's an ongoing um, uh, puzzle where we try to customize to use the best surgical dose for each patient.
Every time I see my neurologist, adding spasticity meds come up, but I'm always like I have made it this far.
Well, that's very good. Everybody knows how awesome you are, and you're going to go way, way, way farther. To me, the way, and this is again my Paulo Selber way of seeing things. To me, people with cerebral palsy are just like any other person. And the way I call them is I just tell them, your difference is that you have stubborn legs or stubborn arms. And that's the difference. And we will try to do whatever we can, with all sorts of available treatments to make those limbs a little less stubborn. I hope it makes sense to your audience.
Do you think everyone has to be on spastic meds?
Not really. I think with medicines, I always tell my patients the same story. First of all, the spasticity medication, the drugs themselves, have been around for a long, long time. They're not new drugs. So anybody who goes on those medications, they're not going to be sort of a guinea pig of a new drug because they have been around. But what I've learned from my patients, not from books, but from my patients, is that every patient reacts differently
Okay.
to the medication. And when I say, and I never prescribe these medications, it's usually the neurologists, the
Yeah.
physiatrists, and other professionals. I like to say that I'm just a mechanic. I'm a mechanic of people, and I try to make the mechanics of movement a little bit better. So it's the clinician who prescribes those medicines. And I think what needs to happen is when the patient starts using these medicines, they have to have an open mind
Mm.
because nobody really knows what's going to happen. And I've heard from patients taking the same medication, three different patients at different times of the day. And why? Because they chose those times because they needed the medication to work at those times. For instance, I have a patient from Australia who told me he never took it in the morning because otherwise he would sleep at the university and wouldn't learn anything.
Yeah.
I had another patient who told me that he used to take the medication at 5 a.m. because then he would be in bed for another 2 hours. He was a lazy, lazy guy. Got up at 7. I get up at 4. But he was lazy, but he took the medication at 5, and by 7 o'clock, the medication had kicked in, and he was more relaxed, so he could go on. And finally, I had yet another patient, and I remember her very well. She told me she liked to take the medication before going to bed because she realized that when she did it that way, she would have a better night's sleep and more energy the next day. So you see what I'm trying to say? Medicine for spasticity and dystonia is very unique in the way it acts for everybody. And people have to, with their doctors, if they need medication, they need to try and control the movements. They need to see which medication works better for them, which dose, and which time. So it's not a, like Tylenol, you take it eight, 4 times a day or 3 times a day. It's all over the place, and people get used and they discover with their doctors first if the medication is working or not, and then if it is, how much they should take, and at times how often they should take.
These share practical strategies for making orthopedic disorders manageable in adults.
Well, always evaluate them the same way. Uh, as I said, when they're ambulators or when they walk, always use gait analysis. Don't make decisions without gait analysis. Is I've learned that from my mentors in the past, including Dr. Lou Diaz and Dr. Jim Gage and Dr. Ivan Ferreto in Brazil. And I've always followed their lessons. I've always used gait analysis. And if I don't have a gait lab available, then I'm not going to work in this or that place. And I've been fortunate. I've worked with 7 gait labs since I started my career. I don't think there's anybody who's been to more labs and worked with more labs than I. I think gait analysis is crucial to try and make the best or to find the best surgical dose. And in non-ambulatory patients, in patients that use a wheelchair, I think the decisions have to be part of a multidisciplinary team. Anytime I see someone, and that applies to the ambulators as well. But I always see them with the physiatrist, or if they haven't seen the physiatrist, I will refer them to the physiatrist. The physiatrist does the same. She refers them to me. And then we talk to the physical therapists, and we talk to a lot of people before we make any decision. And of course, we talk a lot, as you know, to the patients as well. And I think all my patients, they know how much I chat.
Mm.
In 2016, my left leg brace kept breaking and I started getting blisters repeatedly. We went to the orthotist and a physiatrist referral was made. My high muscle tone was making them break. The physiatrist of course offered the CP treatments that I opted not to pursue. So the orthotist made me a new brace with an extra smaller piece to put on before I put my left brace on.
Yeah, that's usually a clever idea. When sometimes braces can be not adequate, but it's usually not the case. It's usually the foot or the knee or whatever part where the brace is being used that fights against the brace. The foot wants to be in one position and the brace wants it to be in another position, and the two fight like cats and dogs. And that's why there's pressure and there's pain and there's rubbing the skin and so on. So, yeah, sometimes we have to ask the orthotists to make the brace so that the brace accepts the position where the foot wants to be and not tries to force it elsewhere, because we know that braces do not fix deformities. And sometimes we have to try and go there and treat those muscles with whatever methods to try and bring the foot or the knee or whatever to a better position so that a brace can be used. So every case is different, and that's why we need to evaluate them carefully. And orthotists are very, very wise people, and they know a lot about their job. And I always discuss with them in not telling them what to do, but listening from them what they think we should do. So this is a team. It's not. I'm not the most important part of the team by any definition. It's everybody together, and we need to talk. So when I call physical therapists here in the United States to tell them what they think about the patient and what we're planning and so on, they're always surprised because they say, "Oh, not a lot of people talk to us." And well, I love physical therapists to the point that I'm married to one of them. And I like to say that we make the patients sore because we do operations, and it is the physical therapists who heal them and to get them back on track. So it's teamwork. It's always been teamwork, and it's always going to be teamwork.
In fall 2021, I had lower back pain and a bump pain started. The X-ray said I had an exaggerated convex contour to the sacrum representing normal anatomical variation. It does bother me not just in my lower back but also on that bump, on my sides, and in my neck sometimes or just so different. It only goes in spurts now. It's at the lumbosacral junction. Two other factors are that I push on my feet to reposition myself while sitting and look down a lot.
Yeah, spinal problems in patients with cerebral palsy are not uncommon. And some of them, in my opinion, result from orthopedic surgeries. When children primarily have their hamstrings lengthened to get the knees to extend more or to stretch more, hamstrings lengthening surgeries are very good to get the knees to extend more. But people forget that hamstrings come from the pelvis and they help hold the pelvis in good alignment. So when we lengthen the hamstrings, which is something that I don't necessarily do, it's good for the knees, but not so often good for the pelvis. And in my opinion, and we've been investigating that more these days, that can lead to back pain. But moving constantly can also lead to back pain. So if you have back pain, I would advise that you go and see a spine surgeon and the physiatrist because they need to know and they need to see and make sure sometimes they need to have MRIs and x-rays to see if there's anything that can be done to improve that.
Luckily, I
I
haven't
don't treat
had
the
any
spine.
surgery.
Sorry, I don't treat the spine. I only treat from the hips down. So I don't know much about the spine. Sorry about that.
Luckily, I haven't had any surgeries.
Good on you.
Thank you, Dr. Selber, for doing this with me. It was great to have you on. Please share this talk show with your family, friends, clients, and colleagues. Everyone watching, don't forget to like, follow, subscribe, and share on Facebook, Instagram, and YouTube.